Good morning, everyone, in person and online. My name is Abby Schlesinger. I'm Clinical Chief of Integrated Care in Child and Adolescent Psychiatry and for Children's in Western. And I have the pleasure today of introducing my colleague and friend, Jack Rozel. I was so excited to see that he was picked to speak here because I think I go way back with Jack. I remember being a resident, being so impressed with his commitment to complicated patients, complicated situations, and compassionate care. And I think he's really sort of shown that throughout his career. We were so excited when he returned to us from Buffalo to lead the Resolve Crisis Network. It was no surprise that when the 988 initiative started, that he was sort of at the ground, both advocating for appropriate financing as well as making sure that Resolve was a part of that initiative. Today, he's talking about never let a crisis go to waste, responding to mental health needs in children, adolescents, and families. As I said, there's no one that could do this probably better. He both has a full appointment of psychiatry as a full professor and an adjunct to law. As I said, there's no complicated patient or complicated situation that Jack would walk away from. And I learn something every time I hear him speak. So with no further ado, let's have Jack Rozel speak.
All right, good morning. So I am delighted to be here with you. Just to go. All right, so I spent about half of my life doing emergency psychiatry, emergency mental health, that type of stuff. When I was in college a long time ago, I started off as a hotline volunteer at a suicide hotline, and I sort of got bit by the bug and never really turned back. And I spent about half my life doing violent stuff, and a little bit of that may come up, but not a ton, right? As far as commercial disclosures, I'm proud to say I've been pharma-free for about 15 years, but I do a lot of sort of consulting, training type of stuff. The other thing I will say, especially mindful that a number of folks are joining from online, the running joke in my family. So my little girl, she's 11, almost 12, and she's at home right now waiting for me to come back home so we can go off on another little trip for another talk. But the running joke is always, Daddy, what are you talking about today? And my answer is always rainbows and puppy dogs, because legit, of my whole repertoire of stuff I teach and train about, this is the lightest stuff I touch on. But for those of you who may be at home on Zoom with, a little lap buddy with you, keep in mind that this may be a bit of a sensitive topic, right? But if nothing else, if it hits a sensitive point, you got to turn off, you got to step up, you got to answer a call. These are some of the key points I want you to take away, right? Three things I want you to think about sort of crisis work in general, right? We got to understand the crisis that's happening in child and adolescent mental health today. And the reality is it's really complex. It doesn't have a simple answer. And there's good news and bad news about that when we come to try and fix it, right? We've got a lot of systems and services out there, a lot of different interventions. And we've got to, pick interventions when we can, but we also have to be comfortable pivoting as situations evolve. And then I'm going to give you some sort of brass tacks tips about what do you do when you walk out of here in 55 minutes and you've got an issue up on the floor, you've got an issue out in your clinic, and you've got that next kid, that next family who's in crisis, and oh crap, what do I do next, right? And so we'll talk a little bit about that as well, right? All right, so what's the crisis, right? We've all seen the news, and I'm going to give you a couple videos, and let's see, here we go.
In tonight's Health Watch, we're looking at the mental health crisis among Americans' youth.
According to the CDC, hospital admissions data shows the number of teenage girls who have been suicidal has increased 50% nationwide since 2019.
For decades, there's been that Surgeon General's warning on packs of cigarettes. But this morning, for the first time, a new warning about something else: social media and what it means for kids' mental health. Why now for this advisory?
We're issuing this advisory to sound the alarm.
Sir.
The alarm, right? Like, it's a crisis. All these bad things are happening. And people want to point at sort of the easy, recent stuff. And one of my good friends and mentors, Stephanie Lida, she's a forensic psychologist out in Connecticut. And one of her taglines is always, beware the shiny object. When we get frightened, we get dumb. our cognition restricts. We focus on sort of the easy, bright, shiny objects in front of us and say, that must be responsible, right? And the reality is that what's happening in child and adolescent mental health, it's a big complex thing. There's a lot of moving parts in the lives of our children and the lives of our families. And a lot of people want to say, "Oh, it was COVID, it was what we did with the schools, it's lack of access to services, it's social media, it's vaping, it's access to books in the school library, apparently too, right? It's all these things that people are really upset about, right? And it's not just one of those things. It's probably like all those things and more, right? But we sort of latch onto something easy that we can put our head around, that we can blame. And we sort of say, let's put a margin around that, right? Because the reality is, social media, for some kids, it's life-saving. For our LGBT youth who have that chance to sort of, hey, like, before I figured out my identity and how I want to understand this as I interact with my family who may not be super approving, I have a really supportive place online where I can explore this. But for some kids, what happens online with social media is awful, right? It's always an individualized assessment, just like everything else we do in medicine. It's the kid who's, sitting in the office in front of us, right? So we do a lot of research, we do a lot of studies, and we find a lot of things have been driving this child and adolescent mental health crisis, right? And a lot of people sort of in peak COVID, it was, if we close the school, suicide rates will go up, right? And, a lot of people blame so many things around COVID and the vaccinations and wearing masks and what are the impacts of that? And it's become this really big red herring in the dialogue around child and adolescent mental health. If you look at the suicide rates for children and adolescents in the United States for the 20 years before COVID, they were getting worse and worse and worse and worse. And during COVID, actually, mostly they leveled out. There was a protective privilege in place. Suicide rates tended to go down for Caucasians. They tended to go up in Black and Brown communities during that time, right? But, it's like, oh, if they're not in school, they'll be at more risk. Actually, again, we talk to our kids, a lot of them not having an awesome time in school. School can be a really stressful place to be when you're a child or an adolescent, right? And so actually getting some of these folks out of school ended up being really helpful. The risk was that we didn't have as good optics on them. We didn't have teachers looking at the kid. We didn't have immediate access to a school counselor, and that sort of made it tricky. But there's a lot of moving parts, and there's a lot of stuff shifting over time, and it makes it hard to sort of point to a good research study that says, this is what'll explain what's going on. So it's complex. There's a lot of stuff that's going into it, but it's also complex in both the colloquial and the scientific sense of the term. And there's good parts and bad parts to that. It's a little bit harder to understand, but also it gives us a little bit of latitude when we say, how do we want to fix it for this kid out in front of us? We don't have to latch on to one perfect study. We can say, what's likely to help this kid based on what the kid's telling us, based on what the family's telling us, right? The other thing is, between COVID and everything else that's been happening over the past few years, it's been a rough couple years for kids growing up in this generation. The meme that's been going around is, wouldn't it be great if we just could have some precedented times just for a little bit, right? And especially with what we've gone through, between COVID, remote schooling, all those types of impacts, it was a crisis and it was a disaster at a broad social scale. And one of the things we know about how disasters work and how disaster response works, and I do a lot of stuff around emergency management, is usually it's never just one thing, right? My wife just touched down in England. She's a musician. She's there for a music festival, and her flight, she flew out yesterday out of Pittsburgh, and it was it was a mess because it was on Delta, right? A lot of you heard about Delta having all these airline issues, right? Was it CrowdStrike? Well, maybe, kind of, sort of. I don't know how many of you came into the blue screen of death last Friday morning, but we opened up command centers across UPMC to deal with, 25,000 computers that were bricked by that incident, right? But for Delta, it wasn't just one thing. That was the first thing. It was a cascade failure, right? Just like that kid in the ICU. It's not just one thing. One organ system goes and then the next and then the next, and it's kind of like dominoes. And that's what we see in major disasters. It's not just one thing. One incident kicks it off, but then what happens is there are underlying and inherent flaws in the system, and those little cracks get larger and the fissures widen. And that's how these situations kind of evolve. And I don't know if any of y'all been watching the news recently. but it's been lively, right? And the day-to-day experiences of our kids as they're trying to focus on what's happening in school, what's being thrown at them through social media and through their peer networks, what they're overhearing from their parents, what they have to see that their teachers deal with about sort of balancing, education versus, rights of parents and all these other really complex things that directly impact their school experience. It's a lot to put on anyone's shoulders, let alone the developing brain of a child or adolescent. And one of the things that I learned back in residency is that when there's stress in a system, just as I said, when there's a disaster occurs, it sort of reveals the inherent flaws in the system. When stress occurs in a family, often it comes out in the kid, right? The metaphor, what one of my mentors, Aaron Malley, used to talk about is you imagine sort of the family holding up this table with all these heavy things on it, right? And the little kid in the family, like everything starts sliding towards the kid because the little kid is not the strongest one in the family, right? And it's not that they're screwing it up, it's that it was a big burden for everyone to bear, and they just happen to be the soft spot in the system, right? And so a lot of times when we see a kid coming in crisis, what we're seeing is the tip of the iceberg. And underneath the surface is a lot of stuff happening in the peer systems and the family systems around them. And we've got to look deeper to what may be driving that, right? And oh yeah, right. So this was a nice study. It came out in Molecular Psychiatry just a couple weeks ago, and it does a real nice job of sort of saying, hey, look, when we look at onset of most of our psychiatric illnesses, almost everything is happening in your space as pediatricians. Almost all of it is happening in childhood and adolescence, right? There's a couple ones that sort of, peak a little bit later, but we should see at least the first whiffs of most of our major illnesses, right? So yeah, it's kind of normative and expected that we'll see, kids showing some types of symptoms. And oh, by the way, if you Google like how many people have mental illness or something else, you'll find numbers like 15% or 25%, or maybe 18% of people have evidence of depression. When you really do the broader population studies, in the United States, at least 50% of people will meet criteria for at least one diagnosis by the time you reach, I'll say I'm middle age. We'll go with middle age, right? Dr. Schlesinger, we're just having this conversation of, as we mature in our careers, what does that mean, right? So yeah, the causes of the mental health crisis between what's happening with the kids, what's happening to access, trying to create a multitude of different ways for people to access services, but realizing there's so many different barriers and so many different needs. It's complex. And when we think about complexity, we think about sort of the scientific elements of complexity, of sort of a dynamic system of, different inputs can lead to different outputs, and there's some general patterns, but there's always individual deviation. And again, some of the comforting parts of this is that we don't have to latch on to one perfect solution. And especially as clinicians, we don't necessarily have to lose too much sleep over the broader system issues. Well, sorry, some folks get to worry about some of the broader system issues, but most of us as, clinicians, boots on the ground folks, it's the kid in front of us, the family who's presented seeking that support, and we can focus on what their issues are and what their needs are, right? So what are some of the things in place, right? Well, if your community relies, as most do, on law enforcement to respond to a mental health emergency, right? And by the way, here in Allegheny County, even in a county as well-resourced as we are here, most people, when they're in crisis or when they see someone in crisis, they're going to pick up the phone and call 911, right? And people sort of know 911, 911's around. It's got songs, it's got TV shows. It's like, it's for most of us, we've had it for all of our lives, right? It's that 3-digit number. And whether someone's, trying to, rob the bank or someone's having a heart attack, we call 911, right? And in the eyes of the dispatcher, the call takers at these dispatch centers, they have a very rigid view of the world, right? They have these very specific flow charts, what to ask, and it leads them to sort of the 3 boxes of disposition. You can send a cop, you can send a firefighter, you can send a paramedic. And by the way, if you aren't sure what to do, you're probably going to send a cop, right? And so a lot of times the behavioral emergency gets a cop. Most of the time, that goes okay, even well. Sometimes it goes amazingly well. And sometimes it is awful. Sometimes it leads to use of force. It leads to criminal arrest. It leads to the shooting and killing of a person who is having a psychiatric emergency for no other reason than that was how it unfolded, because we do a really good job at training and preparing our law enforcement professionals to understand the criminal code, to identify and work up criminal cases, and to do a little bit of social work along the side. But when you're managed and supervised around issues of arrest reports and complaints and use of force, and can you go to the range and demonstrate competency with your weapon twice a year, but you're not asked to demonstrate competency and verbal de-escalation and being compassionate with someone in crisis, with trying to get through a conversation with someone without dropping the F-bomb 6 times, which for me is a challenge. I've gone this far into a grand rounds without dropping the F-bomb. I'm proud of myself, right? Right, but you get a different kind of an outcome, right? Sometimes law enforcement and a crisis response is essential, and sometimes it is deadly. And calling for help before a crisis becomes a crisis sounds great. That's been part of the mantra over at Resolve Crisis Services since we were created. But thinking about who comes to the door after you call for help is a big part of that equation. Because if cops come, it has a whole different impact on what could happen in that family. And the calculus that has to go through the mind of a family when their loved one is having a psychotic episode, is having suicidal thoughts of thinking, I really need help, and who's going to get here the quickest? And if it's the cops, what does that mean? It plays out a little differently depending on your neighborhood, depending on your ethnicity and your social context, right? And there's some very real implications of that. And it's a lot of pressure to put on the loved one of someone in crisis, or to put on that person who's in crisis themselves, right? So we've got to think about how we approach that, right? And a lot of you know that here in Pittsburgh, we were the origin of sort of modern American paramedics 60 years ago at Freedom House. If you haven't heard the story, it's an amazing story. You should bring that in as a grand rounds. It's phenomenal. But we're kind of at the same inflection point in the world of psychiatry, right? But before we had paramedics, the people who might respond might be the funeral director or the coroner for the county, right? And if you can imagine, you're lying on the side of the road with a broken leg, and the guy who comes out is the funeral director, and is, well, how weak and thready is that pulse, right? There's some financial incentives there, kind of like, the paramedic goes out and they get paid when they bring someone to the ER. They don't get paid to stabilize somebody in the community. So you get different outcomes, right? Well, we all know what number to call if someone's having a heart attack, or, if there's been a shooting, or if there's been a crime, or a house is on fire. How many of you know what number to call if someone's having a mental health emergency? Seeing a couple of hands, right? 988, right? So 2 years ago, last week, 988 officially went live. Now, by the way, we've been working on it for years before that, but the official start date, when every telephone carrier in the United States had to reroute 988 to a member of the National Suicide and Prevention Crisis Lifeline, happened just 2 years ago. Now, to be clear, this wasn't just the creation of a 3-digit number. It was also a rebranding of the service, right? And I remember in some of these early meetings, says, well, we're the National Suicide Prevention Lifeline. We want this 3-digit number. What do we want to do with calls that aren't suicidal? What do we want to do with calls where someone's, using substances or something else? And guess what? It doesn't matter what we want, right? It matters what that person or that family wants, because again, when you're in crisis, the last thing you need to do is say, well, it's this number for this service, it's this number for adults, this number for kids, this number for drugs, this number for LGBTQ issues, blah, blah, blah. Right? So listen, we just need to make it as inclusive as we can. And we also need to recognize that the more sort of numbers we throw at the front of that call, right? Press 1 if you're a veteran, press 2 for Spanish language, press 3 for LGBT. We have a sort of a special subnet with the Trevor Project. What happens is the more of those options we add to the menu, the more people say, I can't deal with all this, and they hang up. And that's a missed opportunity to help someone in crisis, right? But we're now live. And this, so 988 now maps out to about 250 local crisis centers across the country, and another 20 or so sort of national sweep centers. And here in Allegheny County, is Resolve Crisis Services. We take all the 988 calls that come from 412 phones, as well as a subset of the 724 calls. It's based on your area code and the prefix of the phone you're calling from, which is awesome if you're calling from a landline here in Allegheny County, or if you have a 412 cell phone. But I'm seeing a lot of, I think, residents and med students. How many of y'all have a area code that's not 412, right? So, right. So it's a tricky thing. And that's why we still have our 10-digit number out there, right? And so Resolve Crisis Services has been here in Allegheny County since 2008. And the idea was to pull together all the core crisis services for the greater Pittsburgh region. And so we do phones, right? So we've got our 10-digit line. We're the 988 partner for the region. We also do some text and crisis messaging support for the National Suicide Prevention Lifeline. So if you text 988, you can interact that way, which, by the way, is different than 741-741, which is the National Crisis text system, which is also very good, also very wonderful. We partner with them very, very closely, right? We have mobile crisis services. 30 or more times a day, every day, we send mobile crisis teams out all over Allegheny County. And I always joke, we're kind of like vampires. If you invite us, we'll let you in, right? Now, to be clear, if you've got a kid up on the floors with depression or OCD that's really bad, call the CL service, right? We aren't going to replicate an existing service. But you know what? For that kid who just flew halfway across the country or halfway across the world for the pancreas, left kidney, right elbow transplant, right? And mom and dad are at the bedside, but one of them left their bottle of medications for their, effects or their lithium halfway across the world. Give us a call. We can help with that, right? We can help with sort of those non-bedded folks, right? We have embedded family peer supports in our mobile crisis services. We have a walk-in program where folks can come in any age, any issue. It doesn't have to be about a diagnosis or a symptom. I'm tired, I'm cold, my family's driving me nuts. I hate my boss, whatever, right? You come in, hang out, you meet with a clinician, you meet with a nurse, often you meet with a peer specialist as well. And we'll work with folks of any age in those programs. On one weekend, I saw a 3-year-old and a 103-year-old in the same weekend. And I felt a little stretched, to say the least, right? We have a crisis residential. This is a program where you actually do have to be 14 or older, and we do have to have sort of a traditional psychiatric admittable diagnosis, but we can also be creative around that if we need to be as well. We have the Downtown Firehouse program where we actually have a street team of about half a dozen folks working downtown to do high-intensity interventions with the unhoused folks. Resolve crisis services are provided 24/7, 365. There's no back billing. There's no copay. There is no wallet biopsy. If you ask for help, you get help. No barriers, right? If you happen to have a Health Choices insurance plan, guess what? That Health Choices insurance plan will get billed for the service. If you happen to have she insurance, like, the Pitt Panther Plus whatever HMO that I'm on, Allegheny County pays for my services. It's a whole separate discussion, but also that means if you are unhoused, if you have no insurance at all, if you're indigent, Allegheny County pays for your services, right? We have someone who's receiving really high intensity services in a Midwestern state and sort of got booted off the bus at the Greyhound station early this morning. Allegheny County is going to help pay for those services while we help support them, right? And again, 24/7, 365. It's voluntary, but we assist with involuntary processes. And we're sort of anchored to that person and family-centered model of what does that person want? Now, what does that mean, right? So like in the best of all worlds, kiddos in distress, and like the friend, the family, the teacher says, kids in distress, let's get Resolve out here, or let's, in some other region, let's get whatever the local crisis service is, right? And so 988, a mobile crisis team, CIT, which is where we have specially trained law enforcement professionals who are who are much more skilled in working with people in crisis, come out. They're there quickly. By the way, most of our mobile crisis dispatches are on site within an hour or two, which is great, but not if there's like people at each other's necks, right? All the right interventions are done. There's, a good identification of clinical issues, appropriate handoff to any appropriate mental health or social services. And by the way, when they say, hey, you're going to be able to go to this clinic for services, that clinic has openings like Monday afternoon and not, September, right? And we all know about some of the barriers to accessing mental health services. And then, of course, peace on earth, kumbaya, and everything's happy and perfect, right? And we all fully appreciate that that is not exactly how it goes, right? Because sometimes people are really ill and have a bona fide psychiatric emergency, right? So an arbitrary definition of sort of what's a psychiatric emergency, like what needs to go over to the PES. It's something that where you've got to have smart eyes, like a doc or a APP looking at this person and figuring out really quickly, is there a life-threatening psychiatric condition going on, right? You know, is that part of our differential? Do they need, ER stabilization or inpatient stabilization? A bridge script, an outpatient referral, not a good use of a psychiatric emergency service, right? But kind of like the medical stuff, right? Is it an asthma attack or is it an asthma attack where we might have to tube them, right? Sometimes it's definitely an emergency. And sometimes, even if it ends up being a nothing burger, you still want them in the ER to make that decision, right? And at a very basic level, the equation of emergency psychiatry is if you've got the right diagnosis and if you're dangerous enough, we're going to admit you. And if not, we'll sort of shuffle you on somewhere else. Emergency services usually begin with 911 dispatch services. Most people with behavioral health emergencies across our country go to the emergency department, which might not be a child, might not have a pediatric EM doc, which might not have psychiatric specialists. Some of them might have a clinician, a social worker, something like that. Some of them might have teleevaluation. Some areas you might be lucky enough to have a PES or even a PES with dedicated child and adolescent specialists, right? The gold standard is, a separate space and specialized staff. But the reality is the vast majority of people across our country don't have access to those types of services, right? Again, imminent threats to harm self or others, especially new onset, severe intoxication, severe new onset symptoms that aren't otherwise explained, medical symptoms comorbid with psychiatric symptoms, especially sort of some of these neurologic findings along the way as well. We want to take a much closer look, right? And I always think of it as kind of like the roller coaster, right? You got to be this lethal to ride the ride, right? If you're suicidal or violent enough, you'll get admitted to the hospital. But if you're not, you probably aren't going to be admitted, right? And so we're really often looking at that imminent risk and often have to explain to families, to law enforcement, to community partners, to school partners that, yeah, this kid was really disruptive. And yeah, he really needs a lot of services and interventions. And yeah, if we admit to an inpatient setting, we're going to positively reinforce some of those behaviors. And the best interventions are these longer term interventions. And that's why they're not being admitted. And that's tricky, right? So what about crisis services, right? So there's a broad array of crisis services across the country. And just like 60 years ago, we were just trying to figure out what, pre-hospital emergency health services could be. We're in that same stage now, working with SAMHSA, a lot of other national partners to figure out sort of what that's going to be at a national level, right? At a very basic level, right? Someone needs help. Or someone is on a pathway where pretty soon their usual resources or usual coping strategies are going to be maxed out and they're going to need more help than they can provide on their own or than their natural system of supports can provide on their own, right? And so here I sort of say it's distress plus dialogue leads to assistance, right? And what Resolve Crisis Services does is sort of the same tripartite core of services that SAMHSA has said this should be our national goal for crisis services, that everyone across the country should have this. And in fact, if you go back about 15 years, there were sort of 3 programs that started off with this model. Ours was one of them. There are 2 others that were originally based in, Arizona and elsewhere. And now we've sort of, in California, we've sort of, spread out these models across the country. And this is what SAMHSA is linking everything to, somebody to talk to, somebody to come to you, somewhere to go, right? And that can be phone services, text messaging, 988. There's a couple crisis centers that are experimenting with sort of like the meta online, world. Like, what does it mean to have like a chat space within Facebook or some of these other online platforms to do these types of interventions? Someone to come to you, right? A lot of times this is mobile crisis services, sometimes partnered directly with law enforcement, sometimes not. In some regions, it's specially trained paramedics. Sometimes we do extended in-home crisis support. So you almost imagine that it's like an IOP or a partial hospital for a kid, but it's brought to the home for, a couple days or a week at the most, right? And someplace to go, right? Because sometimes staying at home doesn't make the crisis better, right? And so that's a safe place to be. That's, maybe not the Hyatt Hotel, but, is a little bit better than the other options, right? So here in Pittsburgh, we have, walk-in and residential programs. We also have crisis respite services for very young children as well. We also, look at sort of what's the spectrum, right? Just because someone's approved for 3 days of residential support doesn't mean that the crisis will be resolved in 3 days, though a lot of times it is, right? And also, you know, we sort of, you know, those add-on services, you know, how do crisis services fit into disaster response, supporting first responders and other people impacted by critical incidents? How do we do this thing that is, you know, threat management, identifying people at risk for violence? Ooh, preview, August 21st, I think, the Pennsylvania AAP, that Wednesday evening webinar. A buddy of mine, Eric Patterson, who's an agent with the Philly FBI office, will be talking to you all about threat management, what you guys can do about that. So preview, right? All right. So 60 years ago, we were just getting ambulances. We were just rolling out 911. By the way, not every part of the US has 911 access, surprisingly enough, although everyone does now have 988 access. Surprising, I know. We were just creating a specialty of emergency medicine. We're just creating professional societies like, you know, ASAP and groups like that. And you can see where we are now with emergency medicine today, you know, 60 years later. We're at that same inflection point in emergency psychiatry. We've got our 3-digit number. We're working on national standards. We are realistically within 5 to 10 years, hopefully maybe less than 5 years, from a subspecialty, an emergency psychiatry that kind of like PEDS EM is, you can come from EM or you can come from PEDS and then you do the fellowship. It'll be you come from psychiatry or you come from EM and then you do the fellowship in emergency psych. We're a lot further along than emergency medicine was in the late 60s, but we sure aren't where they are in the 2020s, but we're going to work and we're going to catch up real fast, right? So a lot of different services, and depending on where you are now, depending on where you are when you're in practice years from now, you have a lot of different options, right? And a lot of times people talk about sort of the spectrum of care, of sort of the lightest touches to the most intensive touches, and they think of it as a spectrum, right? More and more I'm getting used to this idea that think of it as almost a Rosetta, like you're standing in the middle and you've got to be ready to sort of dance to different points. And sometimes you go right to inpatient. Sometimes you start with crisis and then you dial it up, right? Because again, you know, lots of different services, some are accessible, some aren't, pros and cons to each of them, but be ready to pivot quickly, right? All right, so let's get into some brass tacks here, right? So I want you to you know, from the lens of traditional emergency psychiatry, where it's sort of like, what's the diagnosis? Does this require admission? Is there a PRN that we have to give? You know, is this an involuntary admission or not, right? So I'm going to give you a case example here, and you'll have to apply your clinical reasoning and decide whether or not, you know, figuring out the diagnosis and intervention is really what we're doing here, right? So I'll let you just sort of work yourself through this case study on your own. So I may be biased, but I would suggest that emergency psychiatry is awesome and we do really great stuff. We can't do everything. And there's some stuff that won't be fixed with the right diagnosis or the right injection or the right commitment status. And a lot of good clinical problem solving, I think, across medicine, especially as we sort of embrace these broader biopsychosocial models and think about social determinants of health. But oh my gosh, in emergency psychiatry, we got to think outside of that diagnostic box, and we got to think about what are the systems at play, and sort of how do we think about some of these issues. And don't just assume because we've got a really amazing hammer that everything in front of us is a nail, right? Sometimes it's a screw or a bolt or a really anxious turtle, right? All right. So you have this big knot in front of you, and how do you unravel it? How do you make some sense out of it, right? The first 3 things I want you to think about for that next patient or family in crisis, right? First is, what can I do at a practical level? Like, you know, you're just in an outpatient setting, you're just in a specialty clinic, you're just on an inpatient. Like, there's some things you can do, there's some things you can't do. Like, well, what's your actual scope of ability? You may not be able to instantly initiate an admission. You may need to call the TIPS program. You may need to call in other resources. You may need to get a crisis team involved. You may need to, you know, consult with whoever's available, right? You may be able to just sort of provide some immediate comfort and say, hey, yeah, let's put some referrals in place. I realize this is really stressful, but this is something that we can get you set up with some good outpatient services. Hey, we have embedded therapists in our clinic. Isn't that great, right? What should I do? Like, what can I do that's going to be helpful, that's going to take a little bit of the heat out of the system in front of us, that's going to help them understand, you know, what our initial plan is and what comes next, right? Because it's not going to be a one and done intervention, most likely, right? So, you know, we don't expect, you know, primary care providers or specialists in any setting to sort of do long-term treatment of complex psychiatric issues. Although I would also say management of ADHD common mood disorders is well within the scope of primary care providers, right? You guys manage incredibly complex disorders all the time. It is not bumps and sniffles. You know that far better than I do. And managing an SSRI or managing a stimulant, man, it's a piece of cake compared to some of the stuff y'all do every day. So, all right. Critical things to think about. It's if life safety stuff, right? So if someone is talking about killing themselves, especially new onset suicidal thoughts or behaviors, we get really concerned, right? There's a big difference between I want to kill myself or I have a plan to kill myself and I do chronic self-injury and this is part of my chronic self-injury pattern. By the way, both of them can look scary as hell to a parent, but they're not necessarily the same thing. Sometimes pick an easy issue to start off with, right? Someone's in front of you and they've got this whole bucket of crises and problems in their life and their family life and everything that's going on around them. Pick one easy, quick thing that you can maybe easily solve or easily understand and build your alliance and rapport and the trust around that first issue, right? And choose your battles, right? There's some things that we aren't going to get adolescents to really change their behavior on, right? I realize mom and dad are really upset about the music they listen to or something else. Like there's some things you're not going to be able to change about your kid, right? And it's not worth getting in a power struggle unless you can absolutely win that power struggle. And by the way, winning a power struggle means sacrificing a lot of other things. And unless it's a life safety issue, the power struggle is almost certainly not going to be worth it, right? All right. So, you know, I love this cartoon, right? How many of y'all have heard that saying, like, it's just behavioral, right? We throw it around like a slur in psychiatry. And by the way, I work for Western Behavioral Health, so I don't know why so many of my colleagues are hating on it's behavioral, right? Because I thought that's sort of what we were there for. But when a psychiatrist or mental health professional says, oh, it's just behavioral, that's probably our underhanded way of saying there's something about this behavior that's intended to change the system around them, right? So it might be they're talking about feeling suicidal, but it's a way to get a reaction from the system or change the environment around them rather than they're hopelessly, intractably depressed. But by the way, the system around them may really suck. And it may be that the system around them has taught them that the way you get help from that system around you is you up the ante, right? Just because it's behavioral doesn't mean it's not serious. Just because it's behavioral doesn't mean that we can't help. And by the way, if someone is screaming and yelling through their behavior, property destruction, self-injury, suicidal statements, violence towards others or threats towards others, just to get something out of the system, just to be heard, oh my gosh, let's try and find a way to listen to them, right? And the reflection of, oh my gosh, I feel like you were just screaming at me for me to understand something. And I really want to make sure I understand it. Can you help me understand it a little bit better? Because I feel like no one else is able to hear you on this, right? And that can be a really powerful intervention, right? Okay. All right. So think of compassion and empathy as universal precautions, right? Today is Thursday. It's another day in your career. It's another day of hundreds and hundreds of days, where you're working in your practice and your training, right? I know we have work regulations on how long we can work our residents, but I can remember during my intern months at Children's many moons ago being told that because we left the LSU before 8 a.m., it didn't count as a full work day. That was, yeah, Amber remembers that, yeah. Good times, right? Right? But it's not just another day for the kids and the families in front of us, right? And I want to read you a poem, and then I'll tell you where I found the poem because I think it's kind of cool, right? And so here goes. So this may be a normal day at work for you, but it is a big day in my life. The look on your face and the tone of your voice can change my entire view of the world. Remember, I'm not usually this needy or scared. I'm here because I trust you. Help me stay confident. I may look like I'm out of it, but I can hear your conversations. I'm not used to being naked around strangers. Keep that in mind. I'm impatient because I want to get the heck out of here. Nothing personal. I don't speak your language well. You're going to do what to my what? I may only be here for 4 days, but I'll remember you for the rest of my life. Your patients need your patience. Right? What a nice refrain, right? I found this sort of typed onto a plain piece of paper, framed and on a bulletin board in a staff lounge at the Presby Public Safety Office almost 15 years ago, right? So not like out front virtue flag, but sort of back in the staff lounge. And I don't know who wrote this, by the way. I have no idea who wrote this. If you ever find out, please let me know, because they deserve great praise, right? But this was sort of put there by their public safety. This is sort of our spirit. This is what we think about, right? And I think, by the way, here at Children's, you've got, Andy Sherman and his team, they do a really wonderful job. And I think we really work hard to, embrace the spirit across the UPMC system, right? So again, recognize that we're going case to case, primary care every 15 minutes, a new face, right? But this might be the biggest part of the week or the month or the life of that person in front of us, right? Where do you sit, right? In psychiatry, we talk about this a lot, like how do we position ourselves in the room? We don't always think about that in other settings. But by the way, especially in outpatient settings or even in inpatient settings, violence happens, threats happen, people get agitated, people can get seriously injured. Most injuries from violence in workplace settings in America happen against healthcare professionals, you and I and our friends and our partners, right? So where do you sit, right? And by the way, there's no randomized blinded controlled trials on this. There's no good research on this. I've looked, I've tried, I've gotten really interesting looks from the health librarians when I've asked for research on this, because I couldn't find anything and they couldn't find anything either, right? And maybe the gold standard is that like every room where we're encountering a patient should have at least 2 exits, at least 2 doors out of the room. And then facilities keeps giving me this look like that is really expensive. We're not doing that. And they're right. It is really expensive, but we should still do that, right? So the best answer I can give you is think that the door and us and the patient, think of this sort of triangle, right? Both the patient / family should have relatively easy access to the exit, and we should have relatively easy access to the exit. Because a lot of times people really get hurt because someone is escalated and we can't get out of the way fast enough, right? We don't necessarily want to put our hands on contain. We might want to get the hell out of Dodge real fast, right? And if someone's between us and the door, we can get really hurt. And also, a lot of times when someone's pissed off and upset in a clinical setting, they want to get out of that place real fast. And if we're between them and the exit, it's going to hurt because they're going to go through us, right? And so again, as frontline clinicians, it is not our job necessarily to be putting hands on folks. Okay, restraining a patient is a whole different conversation, right? But mostly, like we have specialized teams to be able to do stuff like that, condition supports, et cetera, right? All right, so I'm going to show a short video next, and this made the rounds on social media a little while ago. Then we'll talk about it. It's one of my favorite videos, right? My heart. I know. I love this kid. He is so good. Oh my God. Right. He makes eye contact, right? It's not, hey, you're upset. You need to do some deep breathing. It's let's breathe together. And oh, by the way, if you're walking into a crisis situation, someone's having a meltdown in the waiting room or in a patient room, you might need to take that grounding breath yourself as well, right? The first law of the house of God of that trashy book from the 70s is, the first pulse to take out a code is your own, right? Same concept, right? He makes eye contact. He gently redirects when the other kid isn't getting it. And as soon as the kid's getting it right, he gives them that positive feedback. It says, you're doing great, right? This kid is so good at this. And I don't know how much of it he figured out, how much of it he was taught, but oh my gosh, right? To be able to do that is really important. And by the way, to be able to do that when things are blowing up around you, when people are screaming and yelling and maybe threatening at you, really tough, right? So a little grace and compassion for ourselves as well, right? Couple basic tips, invite an invitation. Hey, my name's Jack Rozel. I'm one of the docs here. I sort of say, you flag your tag, you point at your name and ID. I understand you're upset about something, can we chat for a little bit about this, right? By inviting that invitation, it actually helps people engage with us a little bit better. A little bit of close space is helpful. Too much is bad, right? And the short sleeves in the back corner, that's too far for you to effectively de-escalate me. There's a lot of people in between. And oh yeah, an audience, when you're trying to de-escalate someone, doesn't help because they're performing for them as well as for me, right? But a little bit closer, right? That 6 feet of social distancing that we talk about with COVID might be about the right amount, Eye contact is helpful. Too much eye contact is creepy. You've got to figure that out on your own, but realize that if someone's not comfortable with eye contact because they're neurodiverse, because it's a cultural thing, because it's part of their trauma coping, and I'm forcing my way into their line of sight, it freaks them out and it doesn't de-escalate things. right? Listen and paraphrase, right? Make a genuine effort to understand what they're saying and use paraphrasing. Paraphrasing is really nice, right? Because it slows the rhythm of the conversation down and it lets us fact check to make sure that we're really understanding what they're trying to communicate to us. Because when you are pissed off, frightened, agitated, your frontal lobes are not working great, and your diction and elocution and your ability to formulate a coherent thought isn't always there, right? And the other thing I always say is try and get on their side, metaphorically, if not physically, right? So again, it's not, I'm not de-escalating you because you're agitated. It's you're agitated because we told you we're going to admit you or your kid, 8 hours ago and it still hasn't happened. I'd be upset about that too. Let's find out and try and figure that out together, right? Let me join with you on that problem, right? All right. Also, we could do a whole week of a conference on this, right? Guns don't help crises, period, full stop. And you have national subject matter experts, Dr. Saliba, Dr. Moss, right, who can talk to you about this far better than I can. But yeah, like whatever we can do if we know a kid's in crisis. I realize guns are an important part of the family. I realize, they're important for home defense, but you've had the gun for home defense for X number of months or years. Right here, right now, your kid's in crisis. Right here, right now, we're waiting for that intake for the therapy or the partial hospital. Let's make a short-term change in that habit and that behavior while things are a little bit more heated. Can we find a safer storage option, right? Kind of like, talk about safe sex, it's safer sex. It's not safe storage, it's safer storage. Or by the way, can we get it out of the house, right? Again, we could talk a whole week about that. So some of you probably been doing this long enough that you've encountered one, maybe even two families that aren't super helpful, right? Anyone relate to that one, right? Parents do the best they can. And sometimes the reason the kid's presenting in crisis is because the parents are also in crisis, right? And at first approximation, the parents are doing their best and their intent is benevolent, but their skills may be lacking and they need us to provide that scaffolding for them and sort of teach them how to do it a little bit better and to navigate this new crisis a little bit more successfully, right? And sometimes we know that parents' intent is not always there, right? And know that their frustration may not be with you, but it may be their last encounter. It may be the last, mental health provider they saw that they're struggling with, right? All right. So, parting thought. Good friend of mine, Beast Jane, is a forensic psychiatrist out in New York. And sort of early in COVID, we were doing one of these, Zoom happy hours with a bunch of our buddies and talking about sort of, is healthcare changing and what's happening to the workforce and, how decisions get made. And he had this wonderful metaphor that has stuck with me ever since. And he says, sometimes evolution happens because the water recedes from the swamp and the mangroves adapt and the salamanders adapt. And it's a sort of gradual change. And sometimes evolution happens because the meteoroid hits the side of the planet and a lot of stuff changes really quickly. And I think now in healthcare, even though a lot of the stuff in the lives of children have been changing gradually for a while, now we've also had a meteoroid hit and we've got to deal with both, right? And I love this concept of Eric Hoffer, right? That the only way to predict the future is to have power to shape the future, right? And our role and our responsibility as physicians, even though so much of what we have to do practically is within the four corners of the office or the frame of the screen for telehealth, but don't rest there and realize that your voices to our policymakers, to our leaders, to our elected officials is valuable. And to use the power of your expertise and your experience to leverage the systems to better serve our patients and their families. All right. I think we have about 10 minutes for questions. In case any of you have questions about some of the fun things you've encountered in your lives, I'm happy to take some ideas. This is my contact info. I'm still on that thing called Twitter mess that it is, but I kind of like violence and extremism. Not like that way I like it, but yeah, it's a good place to be. So, all right.